Welcome to Trimester 7 Visceral Disorders and Laboratory Interpretation. This is the introductory session. The course, as described in the catalog, covers the integration of the patient history, physical examination, diagnostic imaging, laboratory and other diagnostic procedures to develop differential diagnoses and a patient management plan. The emphasis will be on the principles of evidence-informed clinical practice. Here is what the schedule looks like. I'm going to be meeting with you 5 hours every week. And of note here, I want to bring to your attention when the examinations are. They're going to be on the first lecture in week 6, week 10, and in the final exam week 15. The course is broken up into 3 sections, and the first examination, the focus is likely to be on the diagnostic approaches, listening in diagnosis, lab uses in diagnosis, and EENT problems. All evaluations are online and require a computer in which Exemplify is downloaded, and there will be no backward navigation to mimic the exams that you are going to be taking in Boards Part 2. The 3 exams, Exam 1, 50 multiple choice questions for 100 points is in week 6, as I said, and it's going to cover the work done from week 1, diagnostic approaches, all the way to week 5, EENT problems. Examination 2, which is going to be held in week 10, similar 50 questions covering from dizziness through to abdominal pain, and the final examination in week 11. Similar 50 multiple choice questions covering the final 4 topics: edema, urinary problems, fatigue, and skin rash, for a total of 300 points. Now, a little bit more about the multiple choice questions. There are going to be 2 types of multiple choice questions. One mimicking the standard NBCE Part 2 questions. There would be 30 questions out of the 50 aimed at the following. What's the most likely diagnosis given a clinical scenario? What's the significance of specific physical signs? And 3, what particular tests are used in order to confirm or rule out various diagnoses, and your ability to interpret positive and negative results. Give an example. Which is the most likely diagnosis in a 67-year-old man with nocturnal low back pain and recurrent infections? There would be 4 choices, and you will be required to choose the best of the 4 choices. Another example would be, what is the significance of low back pain, which is worse at night and not relieved by non-steroidal anti-inflammatory drugs? Again, there will be 4 choices, and only one would be the most correct. And finally, an example of the diagnostic test question. Which test is likely to be positive in multiple myeloma? If you were wondering what were the answers to these 3 questions, the answer to number 1, which is the most likely diagnosis in a 67-year-old man with nocturnal low back pain and recurrent infection, the answer is multiple myeloma. What is the significance of low back pain which is worse at night, meaning nocturnal and not relieved by non-steroidal anti-inflammatory drugs? That the cause of the back pain is not inflammation, but more likely to be cancer. And which test is likely to be positive in multiple myeloma? There are a number of possible tests you will learn. You will learn that if we order the comprehensive metabolic panel, the total proteins will be elevated and the albumin globulin ratio, which is usually 2 to 1, will be reversed. If you ordered a special urine test and it found Bence-Jones proteins, it would be pushing you towards the diagnosis of multiple myeloma. The gold standard is a biopsy of one of the lytic lesions that are seen in the bone, marrow, or throughout the body, would be malignant plasma cells. Now, here is some information about the other type of multiple choice question that you will get in my 3 examinations. This is the Part 3 type of question that is related to a short clinical vignette. It may be focused again on the diagnosis, the test, or identifying statements regarding the clinical picture found in the vignette being correct. Now there are going to be 5 choices, not 4, and there are going to be 2 of these 5 choices that are correct. This is called the extended multiple choice question, and this is typical of, I think, 45% of your Part 3 exam questions. So, covering the bases, which 2 diagnoses should be considered in a 45-year-old female patient with bilateral ptosis? Number 1, cause of bilateral ptosis would be myasthenia gravis. Number 2 would be Lambert-Eaton syndrome. Which 2 tests are likely to be positive in the most likely cause of bilateral ptosis in a 45-year-old female? Now, out of the 2 choices we talked about, myasthenia gravis and Lambert-Eaton syndrome, only one is more likely to occur in a 45-year-old female, and that is myasthenia gravis and not Lambert-Eaton syndrome. Lambert-Eaton syndrome is more likely to occur in a 60-plus-year-old male because it's associated often with a small cell lung cancer, which usually affects older males. So which 2 tests are likely to be positive in myasthenia gravis? One, tensilon, and the other could be either the PEEP test, the IcePack test, or the more definitive test because it has a relatively high specificity would be your anti-acetylcholine receptor antibody test. And then the last question, which 2 statements regarding the most likely cause of bilateral ptosis in a 45-year-old female would be correct? Among the 5, the 2 correct choices could be the most likely diagnosis is myasthenia gravis. The second statement that could be correct might be the anti-acetylcholine receptor antibody test is likely to be positive, or this patient needs to be referred to a neurologist for further evaluation and treatment. There are a number of learning opportunities that are made available to you during this course. 5 lectures per week, as I said. PowerPoint presentations that are going to accompany each of these lectures. Keyword associations that are divided into 3 packets because there's going to be module 1 for exam 1, module 2 for exam 2, and module 3 for exam 3. Summative examinations are also learning opportunities. I would encourage you that after the exam, if you did not do as well as you had hoped to do, please make an appointment with me during my office hours, and we will set up a meeting and we will go over the questions you missed. So that would be part of the review of your exam performance. Here are the recommended texts. None of these are the reference text. These are highly recommended. The Merck Manual of Diagnosis and Therapy, the latest edition. Current Medical Diagnosis and Treatment by Papadakis and others. I'm using the 2023 edition. Bates Guide to Physical Examination and History Taking, the 13th edition. Mosby's Diagnosis and Laboratory Text Reference, the 7th edition. Sousa's Differential Diagnosis and Management for the Chiropractor, and LaRosa's Chiro Essentials Differential Diagnosis, the 7th edition. Now that is not available. The other 5 books are available in the bookstore. The bookstore does not carry any of my books anymore until further notice, but you can look at the website http://chiroessentialbook.com and you can order this book. A little bit more about what books are available on this website. There is part 1, review parts 2 and 3, board's review for physical therapy, obviously differential diagnosis edition 7 for this course, and you would have been had access to purchasing pathology review, and then for the clinic use, a small handbook called Chiro Essentials Intern Survival Guide, and this is in the 3rd edition. Here is what the current 7th edition of Chiro Essentials Differential Diagnosis has. If we look at the table of contents, it would be the first chapter would be on the art and science of diagnosis, which we will begin shortly after this introductory session. Then there's going to be a chapter called The Lost Art of Listening. This has to do with the role of listening in making diagnoses. A section on clinical laboratory diagnosis, which we will use to cover the work in weeks 3 and 4 and the rest of the course. And then a section on symptom approach. There are more than 14 topics. Only 9 of them are going to be covered from this particular book: abdominal pain, chest pain, dizziness, dyspnea, ear, nose, and throat problems, edema, fatigue, skin rash, and urinary problems. And then there is a summary of the summaries at the end, well, somewhere closer to the end and at the very end, what's the diagnosis. So if you were to look at what you've covered, we'll be covering with Dr. Lucente this trimester. Here's the discussion on low back pain. It covers topics like the definition, the impact, and the diagnostic approach, which we will talk about later. I use a diagnostic triad approach to cover more than 15 conditions. And shortly after that introductory page for that particular chapter, there is going to be arranged in alphabetical order a more detailed discussion of each of those conditions. So the first there, because it's in alphabetical order, is ankylosing spondylitis, and it follows a repetitive pattern. What's the definition? What is the etiology? What is the clinical picture? What investigations should be ordered specific for the condition? And what is the management from a perspective of a chiropractor in practice? The what's the diagnosis section follows a similar pattern. It will cover, again, the conditions, and it would be in a table like this. On the right-sided column would be the diagnosis, and on the left side would be the clinical vignette. So if we were to look at the second entry, which has to do with ankylosing spondylitis, the clinical vignette that could appear in board's part 3 would be: a 35-year-old male presents with low back pain and left heel pain. On examination, there is decreased lumbar flexion and extension and lateral bending. There is tenderness over the insertion of the plantar fascia in the left foot. An X-ray of his spine shows bamboo spine with blurring of both SI joints. And with this basic information, you should be able to come up with the diagnosis that this is ankylosing spondylitis. When I use this, I would be changing a couple of things that are, so it's not the exact same. So instead of a 35-year-old male, I would put this down as a 42-year-old male. I would not change this to females because ankylosing spondylitis preferentially affects males 9 to 10 times more than females. I would put low back pain, but I might put right heel pain. I would put in the x-ray, yes, you will see your typical bamboo spine, or I could put, there is syndesmophytes and there is calcification of the paraspinal ligaments and shiny corner signs. How this information is going to be used in the exam is very simple. So let's look at my taking the clinical vignette for the first entry there. What is the most likely diagnosis in an overweight 65-year-old male hypertensive smoker with low back pain and a pulsatile epigastric mass? And the four choices there are ankylosing spondylitis, cauda syndrome, lumbar disc herniation with sciatica, or an abdominal aortic aneurysm. And the answer will be abdominal aortic aneurysm. I could use the same vignette and make a typical Part 3 extended multiple choice question that would go like this, which two statements regarding an overweight 65-year-old male hypertensive smoker with low back pain and a pulsatile epigastric mass are correct. There are your five choices, and the correct choices here, two correct choices are likely to be the best initial investigation is an ultrasound of the abdomen. This is where you are going to actually get a measurement of the diameter of the abdominal aorta. There is nothing here in the clinical vignette that suggests this patient should be referred urgently to the hospital, so B is not correct. This definitely is not a situation of lumbar disc herniation and sciatica because even though there is backache, there is no radiation of that backache into the leg or into the foot. D, if the diameter is greater than 3.5 centimeters, a referral to a vascular surgeon is recommended. So yeah, this is a possible if you're not too sure. So you look at the last choice, lumbar CT scan is recommended to diagnose the lumbar disc herniation. This is not a lumbar disc herniation, so E is not correct. So A and D are the correct answers. A word about attendance. Attendance is highly recommended. It's not overrated, it's highly recommended. However, you are welcome to do what suits you best in order to study well and pass this course. Completion of specific tasks will be used as evidence of attendance, and attendance will be checked compulsory at two specific times during the course. Today, at the end of this session, I will ask you to complete the attendance course in Brightspace, and in week 6, when after you've completed the first examination, those two attendances will be taken to send to Student Affairs as documentation that you actively participated in this course. It will have an impact on whether you get your loans immediately or not. Any questions at this stage? If there are no questions, then we will go to the attendance quiz. Please go into Brightspace, go into Assessments, click on the attendance quiz, and answer the question. The question is actually a poll to see how many of you prefer one particular mode of delivery of this information versus another mode, just for purposes of my seeing if I have to adopt adapt my teaching style to suit more common learning preferences. So please do that right now. And when you're finished, it will probably take 2 minutes. You come back and we conclude this particular session by giving you your first assignment. In the next 10 minutes, what I want you to do is download and read the keywords for diagnostic approaches. We will be covering that in about 10 minutes time. If you have purchased the book already, and I see some of you have, look at chapter 1 in Chiro Essentials, Differential Diagnosis, 7th edition, and what it would cover would be these topics. It would cover what we intend to cover in the first official formal lecture, Diagnostic Approaches. Okay, so I trust that you will take the time to download, read the keywords, because the keywords, you know that I've used keywords before. The keywords are actually a help for you to focus. There is tons of information. Some of it is information that is interesting to have. Some of it is essential. Some of it is uh, good for you to have a basic understanding of the underlying pathophysiology. But the focus of my exams will come straight out from your key words, as was my practice when you had me as your teacher in pathology. All right, so I'll see you back in 10 minutes time. If you have any questions, you can come up and ask me those questions shortly. If not, we'll wait, and then we will pretend that the 10 minutes is up. Okay, so here is the first official topic in Visceral Disorders and Laboratory Interpretation, Trimester 7, Diagnostic Approaches. Before I move on, let me remind you that the application of this information to diagnose yourself or others is strictly forbidden. William Osler, you've heard me talk about him before, one of the greatest medical diagnosticians that ever lived, expressed the same disclaimer slightly differently and probably much better than my bland statement. William Osler, medical doctor, actually born in Port Perry, the same town as Dee Palmer, at a different time. They both left Canada to come over to the United States to make their name. William Osler says, "The doctor who treats himself has a fool for a patient." Now, here are the learning objectives or outcomes for the next 3-4 hours of lectures. At the end of this set of lectures for this week, you should be able to define the term diagnosis. You should be able to describe the 4 laws that govern the art of diagnosis. You should be able to discuss the use of sensitivities and specificities as part of the science of diagnosis. You will list the various purposes of why a diagnosis is made in the chiropractic situation or the medical situation. We would expect you to describe in detail the 4 diagnostic approaches and describe the various components in the patient history, including patient agenda and the spiritual history. The first thing we're going to look at is the word diagnosis. The word diagnosis is derived from two Greek words, dia meaning apart or through, and gnosis to do with knowledge or knowing. Dorland's Medical Dictionary defines the term diagnosis as the art of distinguishing one disease from another. Tabor's Medical Dictionary defines diagnosis as the use of scientific methods to establish the cause and nature of a person's illness. So you can see two dictionaries, two different diagnoses. For the purposes of this class and this course, I define diagnosis as both the art and science of establishing the cause and nature of one's illness. The first of four laws that govern the art of diagnosis is Sutton's Law. Sutton's Law was named after William Sutton, an unrepentant bank robber in Pennsylvania who was locked up more than 40 times for stealing money from banks. And during his illustrious career as a bank robber, while he was in prison, he was interviewed by a news journalist who asked him, "Mr. Sutton, why do you keep robbing banks?" And Willie looked at him as if and said, "Because that's where the money is, duh. I mean, if I want money, I'm not going to go to the supermarket and look in the produce department to see if I find stacks of money there. I can put money down that if I go to the bank, they're going to have money." So Sutton's Law, when applied to diagnosis, says you should put your money on the one sign or symptom or a test that is most likely to give you the diagnosis. This is called the law of odds. And a good example that I use at this stage is if you suspected a patient having diabetes mellitus, the best test that you should be ordering is a fasting blood sugar, not a HbA1c. HbA1c is not used as yet, not yet recommended by the American Diabetic Association as the gold standard for diagnosing diabetes mellitus. It is very useful. It's recommended for the use to monitor the control of the diabetic patient. Fasting blood sugar, if the value is greater than 126 milligrams per deciliter, and I'll repeat that again because there are very few numbers that I will ask you to remember in this course, and this is one of them. The gold standard for diagnosing diabetes mellitus is the fasting blood sugar, and if the blood sugar value is greater than 126 milligrams per deciliter, you have the diagnosis of diabetes mellitus. This is called the law of odds. What are the odds of you having a fasting blood sugar of 244 milligrams per deciliter and having diabetes mellitus? The odds are very great. The second law comes from a 14th century philosopher by the name of William. William was a priest, philosopher from England in a place called Ockham in the 14th century. And William of Ockham, who gave the term to this Occam's razor because it's a very sharp statement, when confronted with many problems, look for one solution. So if you have a patient with a multiplicity of problems, so let me give you a quick scenario and see if you can guess the diagnosis. 45-year-old fatigued divorced female complains of insomnia. She has lost her appetite. She drags her butt around walking, and she has poor concentration and cries a lot. The most likely diagnosis for all of those problems, which could be caused by over 20 diseases, would be depression. This is called the law of parsimony. The word parsimony is an old-fashioned term for stinginess. So this is the law of which you are stingy in your thought process, trying to find one disease that is going to be responsible for more than a handful of symptoms. The third law, a little more recent, 1950, so last century. John Hickam, professor of medicine at Duke University, working with young doctors and medical students training to be doctors, got a little tired of the young doctors and medical students trying to fit 10 symptoms into one diagnosis and can't find one disease that is going to come for each of those 10 at a particular bedside teaching situation. He was heard to have said, patients can have as many diseases as they damn well please. This is called the law of the patient, or Hickam's dictum, after Professor John Hickam. So when you get over into the clinic shortly, you will find out that many people, especially of the older population, may come in not only with low back pain, they may come in with pain in the knee, headaches that are worse in the occipital region. They may come in with a little fatigue, and you're trying to apply Occam's razor to this, and no one disease is fitting. Your clinicians are going to say to you, you may have what is known here in the clinic as a case of high complexity. The patient may have a subluxation that is related to his low back pain. The occipital headaches might be cervicogenic in nature. The fatigue might be related to the fact that the patient is iron deficient, and the patient might have, without any symptoms, hypertension. So look for the possibility of a patient having more than one disease. And the last, slightly before John Hickam's days, this is a statement credited to Theodore Woodward, professor of medicine from Maryland University, who said, if you hear hoofbeats, think of horses and not zebras. When I taught in a medical school back in South Africa, I had to change this around and go, if you hear hoofbeats on the Serengeti plain, think of zebras rather than horses, because horses are not very common in the Serengeti plain. It's more likely to be zebras or wildebeest or water buffaloes. This is also known as the law of common things, or common things are common. I use the term epidemiological approach when we talk about that shortly, instead of going down 10 rabbit holes of the 10 things that could cause back pain using a particular model that has been popularized by Don Murphy. He looks particularly at the four most common things. So this is the law of common things. Now let's look at the science behind making a diagnosis. This is related to sensitivity and specificity and the other things that you've learned coming from sensitivity and specificity, like positive predicted value, negative predicted value, likelihood ratio positive, likelihood ratio negative. We're just going to concentrate on sensitivity and specificity for the purposes of this course. So I'm going to first of all define these two terms, and then in the next slide we're going to talk about the utilization of these two terms. So sensitivity from a definition perspective. Sensitivity is defined as the measure of the true positive or positivity. This is the percentage of people with the disease that have a positive test result. The mnemonic that I would like you to remember is PID, and PID stands for positive in disease. Specificity, on the other hand, if you remember that you learn one and the other one is going to be the exact opposite. If sensitivity is defined as the measure of the true positivity, then specificity will obviously be defined as the measure of the true negativity. This is calculated as the percentage of people without the disease and having a negative test result. The mnemonic is NIH, which stands for negative in health. So please remember this. Sensitivity is a measure of the true positivity and specificity, the measure of the true negativity. The utilization or use of these two terms, which you probably remember more. Sensitivity, the mnemonic you're going to remember is SNOUT. And SNOUT stands for if the result of a very sensitive SN in the mnemonic test is negative N for the N in SNOUT, you can rule out in the SNOUT mnemonic the possibility of the disease. So let's read that again. Two things need to be present for you to be able to use sensitivity of a test. One, the test must be very sensitive. And by sensitive, epidemiologists use 90% as the cutoff. 90% and above sensitivity, good. Below 90, not so good. So it has to be a very sensitive test. The test result has to be negative before you can rule out the possibility of the disease. And remember what I said, specificity is the opposite of sensitivity, and therefore specificity of the test, this is the utilization of specificity. The mnemonic is SPIN, and SPIN, when elaborated, says if the result of a very specific, the SP in specific is the SP in SPIN, is positive, P in positive, P in SPIN, you can rule in the disease. So please remember this. I can guarantee you that you will get at least 2, perhaps 3 questions in your first examination related to sensitivity and specificity. One might be regarding the definition of either sensitivity or specificity. 2 could be related to the use of sensitivity and specificity. 3 could be an application of this. I give you a scenario. In, let's say, fibromyalgia, a new blood test is being researched on and tested right now. And the current research shows that the sensitivity of this new blood test is 84% and the specificity is 96%. Which of the following statements is correct? And you'll get 1 out of 4. And you're looking for a statement that I actually correctly states what the definition of the word sensitivity or specificity means, or a statement that says this test, if positive, can be used to correctly identify the patients with fibromyalgia. Because remember, the specificity in this particular case was very high, and if the result is positive, you can rule that disease in. Okay, so you're warned. So let's bring the 2 bits of information together. So we're going to define sensitivity and we are going to talk about its utilization. Sensitivity is a test of the true positivity. The mnemonic is PID, positive in disease. If the test result of a very sensitive test is negative, you can rule out the disease. The mnemonic is SNOUT. And as I said before, if you just learned sensitivity, specificity is the exact opposite of this. So without looking at the next half of the slide, specificity would be a test of the true Negativity, the mnemonic is negative in health, NIH. The mnemonic is SPIN, and the statement would be if the result of a very specific test is positive, you can rule in the possibility of the disease. And that's exactly what the bottom half of the slide shows. Very easy to remember, but I will test your ability to apply this information in 3 different ways in the first examination. And depending on how you perform as a class, you may find that you get a similar question in the second or the third exam with a slightly different spin to it. You may get it in the form of an extended multiple choice question where you have a clinical vignette and I'm asking you which of the 5 choices are the 2 most correct choices. Okay. Any questions? If there are no questions, let's look at the purpose of needing to make a diagnosis. In the past, when I've taught this course, some students took the stand that diagnoses are only made by medical doctors. Chiropractors don't make diagnoses. They find the subluxation, they remove the subluxation, and they allow the innate to do what the innate does best, which is heal the body. However, embedded in that philosophical statement, which I have no problems with acknowledging as correct, how do you make the diagnosis of a subluxation? You need diagnostic criteria. And you know that chiropractors worldwide are still divided on what is a universal understanding or definition of what a subluxation is. And because of that, your profession has actually allowed the medical profession, who knows nothing about chiropractic care actually, to, through Medicare regulations, define that for a chiropractor to make the diagnosis of a subluxation, you have to use the Medicare PART criteria, and the patient needs to have 2 of this criteria, and 2 of them should be either the A and the R. I'm not going to review this. This is something that you should know already. So, what are the purposes of making a diagnosis? The main purpose of making a diagnosis is to determine the level of intervention. Am I going to treat? Am I not going to treat? Am I going to refer to a specialist or co-manage with a specialist? Am I going to send urgently to the hospital, or is this a 911 call? There is a difference between a 911 call and refer urgently to the hospital. Urgently to the hospital, I'm asking for a family member to come and pick you up and take you to the hospital right now. I expect that you're not going to die in the next 24 to 48 hours. 911 call is, no, I am bringing the hospital to you here in the form of an ambulance because you may die before your relative gets you to the hospital. Is that clear? Okay, that having said, let's look at what warrants a 911 call. There's an A, B, C, D, E that I use to simplify your ability to memorize this. I use a lot of acronyms to help us as aid memoirs. The A in the 911 A, B, C, D, E criteria is airway obstruction. B is for bleeding profusely. C is for chest pain that is lasting more than 10 minutes. D is the distance between you and the hospital. If it is greater than 15 minutes away, the ambulance is likely to get here fast and take you there to save your life. And E would be evidence of disruption of your vital signs. Now, what vital sign disruption am I talking about that warrants a 911 call? 1. Temperature that is greater than 104 degrees Fahrenheit. That is hyperthermia. It could fry, coagulate the proteins in your brain, and you can die from hyperthermia. Or if your temperature is less than 95 degrees Fahrenheit, you can die from hypothermia. Pulse, if you have a tachycardia greater than 150 per minute, or a bradycardia, which is defined as less than 40 beats per minute, 911 call. Respiratory rate disruption in an adult, 30 breaths per minute or above, or less than 8 breaths per minute, 911 call. And if you have a blood pressure greater than 180 over 120, this is malignant hypertension or a hypertensive crisis. You can have a stroke on your way to the hospital. Or if your blood pressure is less than 90 over 50, you are likely to be going into shock, and we need to do something before you get to the hospital. Now let's talk about approaches. There are 4 approaches that are written up in the literature. I have arranged those 4 approaches to spell another acronym. The acronym is PATH, P-A-T-H. The first is pattern recognition. The A is for algorithmic. The T is for traditional. And the H is for hypothetico-deductive. I will not tell you which path you should go down. You will decide which path is best for you at this stage of your development of your diagnostic skills. Pattern recognition is usually the one novices, which is you, are likely to use early up in the game, and then you're going to either experiment with the traditional, the algorithmic, or the hypothetico-deductive. Pattern recognition. This is the patient presents with a particular pattern of signs and symptoms. So let's give you a good example. And this is an example of what is called an illness script. An illness script is a sentence, maybe 1 or 2, that concisely puts what's the main feature. So here's the illness script. This is a scenario of a 10-year-old boy who presents earlier last night with periumbilical pain. 6 hours later, the pain shifted to the right iliac fossa. Now he has a fever, and it started to vomit a few hours ago. What's the diagnosis? And most of you should be able to say at this time, yep, this is acute appendicitis. This is very easy because you've learned this already in your course. Sometimes the pattern recognition is a picture. Here is this woman who is coming into your clinic. She hasn't sat down to say hi, hello, how are you, what's wrong with you. You notice that her face is kind of round. If you had access to a previous photograph a year ago, this is what she looked like a year ago. This pathognomonic feature is called moon face, and obviously if I mention the word moon face, you're going to tell me this is obviously Cushing's disease or syndrome. The word pathognomonic, if we break down that word into its root, pathog has to do with suffering, nomos to do with knowing. So if you saw a patient with this particular picture that she's suffering from, you know exactly what she's suffering from. So moon face, Cushing syndrome. How about this one? Bilateral exophthalmos. I know. Yeah, this is not just hyperthyroidism. This is a particular variety of hyperthyroidism called Graves' disease. Only Graves' disease form of hyperthyroidism causes bilateral exophthalmos. There's no other disease that you need to worry about that is going to cause bilateral exophthalmos. How about this one? You look at the face, you notice the frontal bossing, you notice the square lantern shape of the jaw, and you go, that is acromegaly. How about this patient? Your cousin sent you a cute picture of her 1.5-year-old son. This is your nephew. And she says, "Doesn't Robert look cute?" And you look at this and go, oh. Does anybody know what's wrong with this patient? Yep. There's a tumor growing at the back of the left eye. You no longer see the red reflex. You're seeing a white reflex. This patient has a retinoblastoma, a malignant tumor in the back of the left eye. And this patient needs to be referred urgently off to an ophthalmologist. How about this one? This is a 64-year-old male. And if you look at this, you're going to notice a couple of things. The left upper eyelid is slightly lower than the right upper eyelid. The left pupil is smaller than the right pupil. What you don't notice here or can't see is that the right side of the face is not sweating. The left side of the face is sweating. So the combination of unilateral ptosis, ipsilateral miosis, and anhidrosis is diagnostic for, yes, you're right, Horner syndrome. Now, if I gave you a little bit more information, I said to you, he has been smoking 2 packs of cigarettes for the last 30 years. Can you tell me what is the cause of the Horner syndrome and where it is? Now, with a history of smoking 2 packs of cigarettes for the last 30 years, and this presentation tells me this is likely to be lung cancer. Where would this lung cancer be? This lung cancer is going to be in the right apex or the apex of the right lung, where it is destroying or invading the sympathetic trunk, in particular the stellate ganglia, and then destroying the sympathetic innervation to the pupil, to the upper eyelid, and to the sweat glands in the skin on the right side. How about this one? 32-year-old patient, sudden onset of, he says, I get up in the morning, I go to shave, and my routine is I usually smile at myself in the mirror and say, "Good morning, handsome. How are you?" And I smile and I go, oh, what has happened? This is obviously Bell's palsy. Can you tell me on which side this is Bell's palsy? And if you said to me the Bell's palsy is on the left side, would you be correct? Let me ask you a question. How do you know that this is not a stroke, a cerebrovascular accident? Because there's a difference between the management of a Bell's palsy and a stroke. A stroke is a 911 call. Bell's palsy, you come and see me in my chiropractic office. How do you know that this is not a stroke and just plain old Bell's palsy? And the answer is the inability to wrinkle the forehead on the affected side tells you this is more likely to be Bell's palsy, which is a lower motor neuron lesion of the facial nerve, as opposed to a cerebrovascular accident, which would be an upper motor neuron lesion. And in an upper motor neuron lesion, the patient will be able to wrinkle the forehead on the affected side. That's easy to do. Look up to the ceiling without moving your head. And if you see furrows on both sides above the eyes, then that's a stroke and that's a 911 call. Don't come into the office. Have your relative call 911 and wait for the ambulance, because this could be the beginning of a stroke. The problem with pattern recognition is if you have never seen the pattern before, then, or you saw it ages ago and it didn't register, so it didn't fix in your long-term memory, then you're not going to recognize the pattern. So, what is this? And if you saw this pattern before, you'd be able to tell me in the drop of a hat, this is X. If not, you will tell me this is a twin blade propeller. This is Saturn that has straightened up its rings. This is an olive with a toothpick through it before it gets put on a martini glass. No, this is neither of these things. This is actually a Mexican riding a bicycle. Whoa, what? If I put in the color, that's the sombrero. The two things in front and the back, those are the wheels of the bicycle. And this is a picture from above taken by a drone at a Cinco de Mayo parade. If you don't believe me, here's the parade. If there was a drone above this guy in front there taking a picture from above, you will obviously see that distinctive Mexican riding a bicycle. But as I said, if you've never seen the pattern before or did not commit this to memory, then you're not going to recognize this. So pattern recognition is good up to a point, and then after that you go, I don't recognize this pattern at all. Any questions so far on the pattern recognition approach to making a diagnosis? Let's look at the next in the PATH acronym. A is for algorithmic approach. An algorithmic approach, which is what AI is using right now, is a very simple approach, even though very detailed for deep learning. You ask a question, is it present or absent? Is it yes or no? And if it is yes, you go down a pathway on the right. If it is no, you go down a pathway on the left, and you continue going down several steps in the process. Here is an algorithmic approach taken from Sousa's uh, differential diagnosis and management for the chiropractor. You will do this if you haven't started to do this with Dr. Lucente. It's rather detailed. You start off with a patient who complains of low back pain, and the first is it associated with rapid onset of bilateral leg weakness? The answer is yes. You go across to the right and then you follow that. If the answer is no, you go down and you ask and answer the next question. If it is yes, you go off to the right. If it is no, you go down. And this is the algorithmic approach. Very, very good. It's very detailed, and it only works if you have the algorithm in front of you as part of what's in your office. After you've done this for about 3 months straight, that algorithm now becomes embedded in part of your hippocampus, and it's part of your automatic approach to a patient. Sousa, writing in a paper authored by himself and Hurwitz. The paper is entitled A Theoretical Model for the Development of a Diagnosis-Based Clinical Decision Rule for the Management of Patients with Spinal Pain, written back in 2007. Don Murphy uses the approach, which is a 3-question approach. Question number 1, any patient who presents with spine pain, you ask, is there any red flags, visceral disorder, or potentially serious condition? If the answer is yes, and there are a number of red flag situations that you have learned already because you've gone through this paper in last trimester. If you haven't, then go and grab hold of it and refer to this until the information presented by these two authors is second nature to your practice. So there are 8 red flag situations. We'll talk about them later. I use the acronym red flags. Murphy doesn't. Murphy's a practitioner. He is a scientist. He was not a teacher, and therefore not worried about helping you, the student, to remember this. That's my nature. That's my occupation. And I use the 8 red flags that he points out in a particular order to read or match the acronym red flags, which we will talk about shortly. If there are no red flags, the second question Murphy says to ask is, what's the source of the pain? And instead of going down the 9 or 10 pain sensitive structures in the spine in an anatomical approach to generating a diagnosis, Murphy says, let's cut out all of that. I'll tell you from my 30, 40 years of experience as a clinician, only 4 are the most common. They are probably 90 to 95% of all of the causes of back pain. One is internal disc derangement, so disc pathology. Number 2 would be joint pathology, in particular the facet joint. Number 3 would be nerve root problem, and number 4 would be muscle problem. And Murphy says there are a number of ways to do this. If I find evidence of centralization of pain, and you know what the term centralization means, this is Mackenzie's centralization signs, then you have a disc problem. If there are no centralization signs, you provoke the joint by doing a Kemp's test, laterally bend and extend into the area that is painful. If the patient goes, ow, that hurts, you have provoked the segment, you have isolated the pain as possibly coming from the facet joint, whether it be facet joint pathology or a subluxation. If there is no exaggeration of the pain with segmental provocation, you do neurodynamic signs. And if that is positive, and the neurodynamic sign you're going to use that has the highest specificity is the well leg raise test. You could follow this by the straight leg raise test that has the highest sensitivity. And if these are positive, then you know that it is radiculopathy. You can then base off of the presentation, the dermatomal pattern, whether this is L4, L5, or S1 causing the back pain. And then if it's none of those, neither disc, not joint, not nerve, then look for areas in specific muscles that when you press on it, it triggers not only pain, but it triggers a pattern of pain radiation. And one of the common causes of muscle pain in the back that may mimic radiculopathy in that it radiates into the butt and may or may not radiate into the upper portion of the posterior thigh would be a trigger point in quadratus lumborum. And then Murphy says, once you have located the source of the pain, then you're going to look at perpetuating factors. These are things that if you don't deal with the dynamic instability, the oculomotor dysfunction, problems with the eye affecting the upper cervical region, or dealing with these 4 psychological issues, fear, catastrophizing, passive coping, or depression, that adjustment is not going to be lasting too long. The patient is back in your office 3 months later. You adjust them again, they feel better, they come back 2 months later, and then you keep that repetitive until you go and deal with, I think, having examined your eyes. You may, your headaches that you're feeling primarily at the back of your head, radiating towards the back of the eyeballs, maybe not coming from your neck. You may need to go have your eyes checked properly. I mean, you could go through the process of having a eye chart in your office and do the regular standing away 20 feet, close one eye, yeah, you need to go see a eye specialist in the form of an optician, optometrist, but not an ophthalmologist. Okay, so that's the algorithmic approach. It has its usefulness. When you don't recognize the pattern, 2, you don't have a algorithm that you could follow, or your algorithm is not helping you, what most doctors out in practice fall back on is the traditional approach they learned in chiropractic and medical school, where you take an exhaustive history, you do a detailed physical examination, you come up with five differentials, you order some tests, you come up with a working diet, etc., etc., and then you go back to the traditional approach. So just to remind, we're not going to be going over this, just going to review this time-honored approach that most other health professionals will use. History taking, physical examination, come up with a handful of differential diagnoses, diagnostic imaging or lab test, come up with a working diagnosis. You're going to come up with a treatment plan. And if your treatment plan succeeds, then you have a final diagnosis. If your treatment plan does not succeed, then you're going to have to go back and pick out number two of your five differential diagnoses. I remind you that your history taking covers data collection so that you have the right patient file in front of you. Chief complaint, history of the chief complaint, past medical history, family history, social history, review of systems. You all have been drilled, inculcated, culturated in this particular approach. This approach is very useful. There is a study originally done in 1975, reported in the BMJ, and then there have been four other studies that have been done outside of the United Kingdom, one in the States, one in Australia, two in the Far East, where they have looked at the usefulness of this traditional approach. This particular study by Hampton and others in the BMJ in 1975 estimated that approximately 80% of all patients, the diagnosis could be made just from the history alone. In another 10%, the diagnosis can be made after you've taken the history and done a physical examination. In an additional 5%, the diagnosis is not made on the history or the physical examination, but the diagnosis is clinched by doing lab tests, and we'll talk about that in week 3. And the remaining 5% is the diagnosis is unknown. We use officially the term in medicine idiopathic. I found out more recently from one of the teachers in the clinic that one of our chiropractic students in the clinic refuses to use the term idiopathic because he thought that the word idiopathic means he was an idiot. No, the word idiopathic means we are idiots, we meaning the medical profession, don't know, we are ignoramuses regarding what is the actual cause of this problem. Chronic fatigue syndrome, classic example. Fibromyalgia, we know how to make the diagnosis. We kind of don't know how to treat properly because we still don't know what causes this. And this is why we're having some degree of difficulty not making the diagnosis, but treating the patient because we don't know what we are treating. This is a very useful approach. And I'm going to come back to this and say, when we start next week's work on listening and diagnosis, although we know, and Margaret Bates in her book knows this, and other books on medical interviewing know this, that 80% of the diagnosis of patients with diseases can be made on the history alone. We do not spend 80% of our time teaching you how to take a history or how to listen. So you're going to spend 5 hours with me next week going over the ramifications of how actually to listen in order to improve your diagnostic skills. Next in the PATH approach is the hypothetical deductive approach. This is also known as the Sherlock Holmes approach, and I'll let you know that shortly. This was popularized in the 1970s by an educational psychologist by the name of Arthur Elstein, who overheard At lunch in the cafeteria, one of his medical professors bemoaning the fact, this is in the 1970s, that computers had just come out. They're just getting accustomed to floppy disk rather than hard drives, much less thumb drives, much less stuff in the cloud. And the professor said, the students today are like the floppy disks in computers. You ask them one question, they spit out an answer. You ask them another question, they spit out another answer. Third question, they spit out the answer. You put the three questions together. And I give you an example. I mean, I taught family medicine when I was in South Africa to medical students for a number of years, 12, 13 years. And I had a final year medical student interviewing a patient who was hypertensive on a particular hypertensive drug, also presenting with pain in the ankle. And I said, give me a differential for um, pain in the ankle. Gave me 10 causes. Give me 10 possible side effects of hydrochlorothiazide. Gave me 10 side effects. Give me 5 approaches for treating a patient with hypertension. So he started off with that one. Uh, Non-pharmacological diet manipulation, lose weight, less salt, and then go to drugs. You started off at level 1. If that doesn't work, level 2, level, etc., etc. And this patient was on a thiazide diuretic. He listed all of the known side effects, including, as he spouted out, hyperuricemia. Asked for a differential for the ankle pain. He gave me a whole host of, osteoarthritis, rheumatoid arthritis, SLE, Sjogren's, blah, 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 blah. Couldn't put the three things together and say to me, this patient's ankle pain, which brought him into the clinic today, is actually a complication of putting him on a diuretic, which was causing gout, hyperuricemia. They had all the information. They could not synthesize this. And there are some of you who are going to be very good at listing off these things, but not so good at integrating this together. The hypothetical deductive approach, Elstein overhearing the professors moan that our students are just like computers. When you press one key, you get one answer, another key, another answer, third key. If you were to press two keys accidentally because your finger is a little fat like mine, the computer in those days will go, sorry, bad command. Can't answer that because they asked for two bits of information to be pulled together. Today, that is unlikely to happen. Elstein goes over to their table and says, do you teach these students logic? And they say to him, doc, medicine is an art. And he says, yes, but do you teach them logic from a mathematical perspective? And they got into a discussion, and Elstein says, I think I can help you better teach diagnosis to your students if you allow me to attend your grand rounds and your bedside discussions for the next couple of months. And at the end, he comes back and says, this is what I see you professors are doing. We're talking about teaching them to think like a professor. You listen to a 15-minute presentation by the young intern, giving you every single possible piece of information they've collected, and you pick out one cue. And based on that one cue, you have formed a hypothesis. So let's use this as an example of a condition you already know. You have a 34-year-old woman. She is in her second trimester. She comes complaining of pain and tingling in her left hand that is worse at night. The pain is confined to her thumb and index finger. And when the pain wakes her up at night, she shakes her left wrist, and within a couple of seconds, the pain goes away and she goes back to sleep. Now, in all of that, you probably would have recognized the pattern already. All I heard that was the cue for me was pain and tingling in the thumb and index finger. What hypothesis have you formed? I'll tell you the hypothesis I formed. I went, this is more likely to be, and if you thought carpal tunnel syndrome, you would be absolutely correct. Now, the reason this is called the Sherlock Holmes method, Sherlock Holmes, fictional detective character written by Arthur Conan Doyle. You may not know this, but Arthur Conan Doyle graduated as a medical doctor from a Scottish university and patterned his fictional detective Sherlock Holmes from an actual teacher of his by the name of Joseph Bell. You can actually, in your spare time, if you have a spare time, Google Sherlock Holmes, Joseph Bell, Conan Doyle, and you will find some fascinating information. The story, because I read Sherlock Holmes novels as a child, teenager, and I remember this particular one where Holmes says to his sidekick Watson, "The dog did not bark." And John Watson looked at him and went, "Okay, the dog did not bark. But what am I supposed to infer from that bit of information?" And Sherlock Holmes looked at his friend and shook his head and said, "Because the dog knew the killer." Elementary, my dear Watson. That's why it's called the Sherlock Holmes method. So in this approach, my cue was pain and tingling in the thumb and index finger in the left hand. My hypothesis was or is carpal tunnel syndrome. What test would I perform? I have 4 possible tests. I can do Tinel, tap the wrist. I can do Phelan's. I can do reverse Phelan's, or I can do Durkin's, otherwise known as wrist compression for 30 seconds. If I want it to be based on evidence that is available, I would look for the test that has the highest specificity, that if it is positive, I will use this. And you can go Google, getthediagnosis.org, put in carpal tunnel syndrome, and you will be told what's the specificity for Tinel, Phelan's, reverse Phelan's, and Durkin's test. You pick one of them. The test is positive. I go, yeah. Tinel, when I tap just beyond the distal skin crease at the base of the palm of the hand, it is positive. I go, yep, diagnosis is confirmed, sort of. I have a plan. I am going to adjust the carpal bones of the proximal row to maybe get the lunate back into position. I'm going to recommend the patient wears a wrist brace at night to keep the wrist partially extended. And I will see the patient back for the next couple of weeks. And at the end of my treatment protocol, there is no improvement. Uh-oh. So I've gone through the plan, implemented it, reviewed, did not work. What that should tell me at this stage is maybe carpal tunnel is not the correct hypothesis, and I will go and start the process back at creating a new hypothesis. If I got stuck at doing Tinel at the wrist, and that was negative, Phelan's was negative, reverse Phelan's was negative, Durkin's was negative, I am at that stage reforming my hypothesis. Now, what else could cause pain and tingling in the finger and the thumb, the index finger and the thumb? It could be pronator teres syndrome. The median nerve is pinched between the 2 heads of pronator teres. I do the same. I do a provocative test. I do a tapping test. And if that is negative, I'm coming from distal to proximal. I go up to, is there a problem with my thoracic outlet? I'm going to do my Roos. I'm going to do my Edens. I'm going to do my Wrights. And if that is negative, I'm going, okay, where else could it be? And if you were thinking at this stage, IVF compression of spinal nerve C6, because thumb and index finger is the dermatome of C6, and then you do your tests for maximal cervical compression, you do your Sperlings, you bop them in the head, you etc., and that turns out to be positive, then you can confidently order oblique cervical view, looking for encroachment of the IVF through which spinal nerve C6 comes out, and that would be between C5 and C6, and you have your diagnosis and you have a treatment plan and you review. And if that is not helpful, you back to square one and you're looking for what else could cause tingling in the thumb and the index finger in one hand. Okay. Any questions? If at any time you're listening to this voiceover presentation, you want to take a break, you know you can stop, put it on pause, go have a cup of tea, pee break, potty break, not pot break, sorry, um, and come back. All right, now that you're back with me, let's look at the next topic, differential diagnosis. Now, boards is keen on your knowing not just the diagnosis, but knowing if you can think of two or more causes of common problems. And the clinic does a great job at preparing you well for passing part four, will insist on your learning not just um, one carpal tunnel. It could be responsible for pain in the thumb and the index finger. Two, it could be pronator teres syndrome. Three, it could be TOS, thoracic outlet syndrome. Four, it could be IVF encroachment. Five, it could be something else. It could be the beginning of a syringomyelia, which classically presents with bilateral problems in your hands, but could start off at one specific spinal level before it spreads to involve C5, 6, and 7. So differential diagnosis is a skill you need to be able to develop. There are three approaches that I'm aware of. One is the anatomical approach, where we use our knowledge of the anatomy. We ask what structure is likely to be involved. Two is the pathological approach. We use the mnemonic vindicate. I've added the D, and I'll tell you what the additional D. So the mnemonic you'll learn with me this trimester is vindicated for using the underlying pathology to develop a differential, or what I call Murphy's epidemiological approach, where you're using the three or four most common causes. I usually use the three most common causes of X. So the anatomical approach. If you were to look into this reference, which you did in trimester 1 and 2, Darby and Kramer's Basic and Clinical Anatomy of the Spine, Spinal Cord, and Autonomic Nervous System, 2005, the authors say there are 9 structures that are related to the spine that have free nerve endings capable of perceiving problems and sending signals to the brain to go, that area is under stress because the nociceptors in this area are firing. There are nociceptors found in the skin, and we're going to use an anatomical approach. If you have a needle, a lumbar puncture needle piercing the skin, going through the layers of the skin right into the spinal canal, we will pierce the skin first of all. If we did not use a local anesthetic, the patient will go ow as you went through the skin. As it went through the that is painful. If it went through the supraspinous and interspinous interspinous ligaments, that would be painful. If you touch the bone accidentally, that would be painful. If you jammed up accidentally into one of the facet joints, that would be painful. If you touched a nerve, it would be painful. If you went off course and went through the muscle, that would be painful. The dura is painful and your blood vessels are painful. So you can easily go using this anatomical approach from inside out. Is there cellulitis? Is there panniculitis? Is there ligamentous damage? Is there bony inflammation? Is there joint inflammation? Is the nerve inflamed? Etc., etc. So you can use your anatomical approach to get to the differential diagnosis. The anatomical approach is going to work marvelously when we get to abdominal pain. That's the best approach. You visualize the organs that are beneath the anterior abdominal wall. You push your hand in the right upper quadrant. You ask yourself the question, what structures are underneath there that could be inflamed? You think gallbladder, yes. Cholecystitis, liver, yes. Hepatitis. If you push deeply, you might get the top of the right kidney, pyelonephritis, and you use the anatomical approach very well with abdominal pain. It doesn't work well with other symptoms. Okay, so next we're going to use the pathological approach to generate a whole heap of differential diagnoses. I introduced you in trimester 2 to the mnemonic vindicate. I'm adding a second D, so the current mnemonic is vindicated, and I'll explain why I'm doing that. So V is for vascular. AAA, an abdominal aortic aneurysm, can present with left-sided back pain as the aneurysm gets larger and erodes the the anterior aspect of the vertebral body on the left side between L1 and L4. I is for infections. Could this be osteomyelitis? N is for neoplasia. Could this be bone metastases? D, degenerative. Could this be osteoarthritis? E, iatrogenic. Is your back pain as a result of some intervention by a medical doctor? C is for congenital. Could you be having at age 40 spina bifida, which is usually asymptomatic, but as you get older, may become symptomatic in a small percentage of patients. A is for autoimmune. Do you have ankylosing spondylitis? T is for traumatic. Have you sustained a significant injury causing a fracture to some part of your vertebral bones? E is for endocrine, like hyperparathyroidism, which may cause pathological fractures. D is for drugs, in particular statins or steroid side effects can cause low back pain. The next approach I'm calling the epidemiological approach. I've linked Don Murphy to this. Again, his paper, I refer to it, the clinical decision rule for spine pain diagnosis. Murphy says 3 questions in this order. Are there any red flags? If there are no red flags, what is the pain generator? And once you've identified the pain generator, are there any perpetuating factors? I need you to remember these 3 questions. Okay. Any questions? Let's dive a little bit into history taking. I want to emphasize, or if you haven't done this, teach you this for the first time. Take you back to the traditional approach, which we talked about: history of the chief complaint, past medical history, family, socially review of systems. In the current edition of Bates's Guide to Physical Examination and History Taking, there is a section called Patient Agenda. Did your teachers do patient agenda with you? Bates uses a particular mnemonic called FIFE. Fife is a little reed pipe that is played by military in military bands, fife and drum, very high pitched sound. And the acronym FIFE stands for F for feelings. And here's the question you ask about their agenda. What about your illness worries you the most? I is for ideas. What do you think is the cause of your illness? F is for functional effects. How is this illness affecting your daily life? And E is for expectations. What specifically would you like me to do for you today? And I will go over this patient agenda as part of next week's work in detail, showing you how addressing these four aspects of the patient's agenda are crucial to making the diagnosis. Because if you don't, many times you're likely to end up wasting money, time, and effort chasing the wrong diagnosis because you did not understand where this patient is coming from. Okay. There is a recommended reading that I would like to suggest over the weekend. You read this particular um, paper written by Hashim, published in the American Family Physician Journal 2017. Is entitled Patient Centered Communication Basic Skills. He makes the statement that communication skills needed for patient centered include eliciting the patient's agenda and asking open ended questions, especially early on in the interview, not interrupting the patient, and engaging in focused, active listening. And we will talk about all of those next week. Recommended for those of you who are desiring to be great physicians. Any questions? I need not to remind you that people do not suffer in isolation by choice. No man is an island, entire of itself. Every man is a piece of the continent. We are linked together with one another. This is to quote John Donne. Now, how that is fleshed out in the interview is part of your clinical consultation, your history taking. You should be asking questions related to these five F's, because these five F's are going to be helpful in helping the patient to heal. Tell me more about your family. Is there a supportive family um, in the background that you can rely on to bring you to clinic if you can't drive, to help comfort you? Uh, do you have a close circle of friends that you can confide in if you can't talk to your parents or your spouses? What about finances? Finances may affect whether I order an ultrasound, a CT scan, or an MRI for if you have gallstones, if I suspect cholecystitis due to gallstones. Is there food allergies that I need to be aware of? Is there a particular food that you tend to gravitate towards? I know when I'm stressed, I don't know about the rest of you, I would enjoy a piece of chocolate. Well, it's a piece, and then it's a quarter of a bar, and then it's a half of a bar, and then it's all of the chocolate. And 2 months later, I'm worried, why am I not losing weight? And I'm now more depressed. And then the last would be my faith. People's beliefs may have a positive or negative impact on the way they deal with the illness they are encountering. The outgoing Surgeon General of the United States, Vivek Murthy, in 2024 made this statement in an address to his friends and family and co-workers. Through my work over 2 terms as Surgeon General, I saw the answer to what's missing is simple yet profound: community. The loss of community has become one of the defining challenges of our time. In response, we need a fundamental shift in how we build and prioritize community. This fracturing of community is driving a deeper spiritual crisis that threatens our fundamental well being. WHO is yet to redefine the definition of health and add spiritual well being as part of their definition. They're going to get there one of these days. A medical doctor working with a nursing college by the name of, not the nursing college, her name is Christina Patalski, developed this score. It's called the FICUS score, her mnemonic, not my mnemonic, to help teach nurses and medical professionals and health professionals around the world how to be sensitive to and how to ask the right question related to spiritual issues. She developed the score in 1996 and uses the acronym to remind us that F is for faith, I is for importance, C is for community, and A is for address in care. Now, each of these categories come with an appropriate question. So F for faith. Here's the question: do you have a spiritual belief that helps you to cope with stress or illness? I go to a medical practitioner as part of my primary healthcare circle. He works for Advent Health, and this is embedded in their questionnaire that the nurse assistant or clinician fills in before I get to see my doctor. And they ask me these questions. I ask for importance. Here's the question you asked related to importance. What importance does your faith or belief have in your life? How does it influence how you think about your illness and health and healthcare decisions? C is for community. Do you belong to a spiritual community? It might be a synagogue, it might be a mosque, a temple, a church, it might be a gathering under an old oak tree where everybody takes a deep breath, 4 seconds in, 4 seconds out. Meditate on your navel, 4 seconds in, 4 seconds out. Meditate on your navel, or whatever it is. Do you need to search for another community? Would it help if you found one? And depending on whether you're a Christian or a Muslim or a Hindu or a Jew, I could suggest there's a Beth Israel synagogue just around the corner, or there's a Dharamsala temple in Ocala, etc. And A is for address in care. How do your religious and spiritual beliefs apply to your health? How might we address your spiritual needs in your health care? And if you wanted to read some more, because I know some of you are deep thinkers, you want to be the best healer that God intended you to be, here's a very good summary article. It's a systemic review and meta-analysis published in the Journal of Applied Nursing Research in 2022 The title is The Efficacy of Religious and Spiritual Interventions in Nursing Care to Promote Mental, Physical, and Spiritual Health, a systemic review and meta-analysis. In what I liked about this particular paper, there are tons of references, and you could go back and see. The one that triggered my attention was a one written by Charles Bird back in the 1970s on a very good study. When it was published, it was lambasted because they didn't do this, they didn't do that, etc. Based on people in a coronary care intensive unit, coronary care intensive care unit, and they divided the people, the patients in the ICU beds into two groups. One group uh, was prayed for by members of his Pentecostal church. The other group was not prayed for. They both received the same uh, critical care without any differentiation, and then looked at a number of things. He looked at the use of pain medication. He looked at the length um, of duration of stay. He looked at the number of complications while they were in the ICU and found out that those that were prayed for had less pain medication, healed faster, less complications, etc., compared to the group that were not prayed for. And then got really dinged for it because in those days they had not yet inculcated into the medical researcher the need for informed consent. None of the patients in the study knew that they were being prayed for or not being prayed for. They had no choice. And if you're using prayer, and please bear this in mind, if you are using prayer in your practice, and I do, you need to have permission from your patient the same way I need to have permission from them to give them an injection. You need to get permission from them to adjust them. They need to be aware of the complication side effects of either intervention and need to make an informed consent decision. Any questions? That's the end of this presentation. Just got some homework to mention to you. In preparation for next week, you're going to read the second chapter. It's called The Lost Art of Listening. In preparation for next week's 5 lectures entitled Listening and Diagnosis, you download the appropriate keywords that are found in the content under Module 1, and you review the keywords looking at, yeah, I know this. Yeah, I know. Oh, I'm not familiar with the term oculistics or kinesics. I know kinetics, but not kinesics. And therefore, it will give you an overview as to what we will be discussing next week. Okay. All right. I will see you next week. Enjoy your weekend. Bye for now.